hesitate to say that I'm an expert in the way Canyon Ranch does things, because we are literally separate organizations, and I can't speak for Canyon Ranch, that would be unfair. We have the same name, the same founders, but that's about the extent of it, other than my office is conveniently co-located at Canyon Ranch, which is kind of nice. But,
okay,
so,
Mel, we have questions for you. That was for Mel.
Okay. Sorry, go ahead.
How do you integrate, like, with United Healthcare or Cigna? I mean, are they paying, will they pay for these kind of?
Well, that's, you know, for us, we have about 800 employees. Almost all those employees we insure through an insurance company. I just want to say which one, an insurance company. And so the data we gather, we brought that to the table with our insurer to say, look at what we're able to do here. So we're asking them to subsidize some of those programs and services for our employee base. And that here's the model we're doing, here's that little bit of evidence we have, beginning evidence we have. Now, you mentioned United. United is the group that we're doing the pilot with. So this is with our patients. And the United pulled out for us, patients are the highest risk, you know, that they insure, that they're worried about that get their care with us. And we've applied that model, that integrated deliveries model, not the life enhancement program, but using that cadre of professionals to work with that population. That's where we've seen a decline in the hospital care and costs. And you know, who wants to go to the hospital or the ER? You know, you'd like to get through your life without that experience if it helped us.
To take it full circle, does your successes inform education and curriculum in schools to get it even further around? And the reason I ask is because I've heard that, you know, schools have been, and I don't know if this is correct, cutting out physical education and athletic, right?
Yeah.
So can you talk about public health policy and
Around
how
schools.
you all work together to change public health policy?
So, yeah, so obviously the College of Public Health is very interested in policy, but, you know, I mean, this is tough crack, or tough crack, because, you know, it's driven a lot by all the Ames pressures. And in fact, I just spoke to a junior high this week that we're working on a teen texting program for messaging, health messaging to teens who are in junior high school. And we wanted to deliver it, the initial programming, through a health program, and they said, we don't have health classes anymore, we got rid of health classes. So it is a problem. What we do is with all of our programming that is school-based, we make sure that we have every objective listed out and align it with an Ames requirement, so the teachers can at least go to their administrators and say, this meets these Ames requirements, and we found that that's been fairly effective. But I think the school-based thematic area in our college is really trying to look at it at the state level and see if we can impact this. But all I can tell you is so far we haven't had a lot of headway.
And we've done work in the same sort of mode. One thing we always try to do, that's why everything we do is evaluated, because evidence is the way to change policy.
Right.
So we tailor programs really with one of the ultimate goals, inform the policy process. We don't advocate, we inform. But another one of our partnerships with the place in Colorado Springs is we're creating a diabetes curriculum, K through 12 in English and Spanish. And that's that lever of having to meet the sort of funded objectives is the way that you can do that. But you have to, A, work to change the objectives when they're inappropriate, but B, match the ones that they have. So it's possible, it's just going to take about as long to change that as it took to get us where we're at.
And you have to realize that kids also have after-school programs, before-school programs, Y programs. So we're really trying to hit them at all different times in their day, including in the family setting, understanding that some things will be more effective than others.
Kent.
It seems to me like the basics of this program, especially with the spiritual component and life-changing, life-affirming, would go very easily hand in hand with the recovery community. And people in the recovery community also statistically tend to be high users of healthcare because their bodies are undergoing radical changes in recovering from addiction. What would it take to bring, or have somebody from that community come and learn how to be a coach, to bring that back to that recovery community, and possibly have a higher rate of long-term?
That's a great idea.
That's certainly a doable idea.
Yep, that's right. There's a few requirements for the program. One of them is a healthcare provider. It has to be part of the partnership, right? You need doctors and nurses to be part of the core team. So we could think about doing a group
Yeah.
that specifically focuses on that. We have a group in Missouri that's all diabetics right now, so we could do that focusing.
Because, yeah, it does give them, you know, that common shared experience too. Because you do see the diversity in the groups that come together by convenience or interest or what have you. And I think the other thing to note, you know, as we look across our patients that are most high risk, 30 to 40% of them either have some kind of recovery related to substance abuse or mental health diagnosis. So we know that that's such a critical part of people being able to manage their hypertension or their diabetes. You know, it is that whole person orientation that is powerful.
BJ?
Can you address some of the issues surrounding the historic contamination on the south side of town that has then, you know, led to really this whole center being here?
Yeah.
And how that interacts both with the clinical setting as well as public health?
Yeah. So, does everybody know what he's referring to?
They probably don't, that's why I'm asking.
Yeah, and he's lived here for 30 years, but the history of this huge clinic, over in that older building, there was a little El Pueblo Clinic Health Center that was put in place with funds from, it was Hughes Aircraft at the time that was dumping TCE into the water supply. And, you know, that led to, obviously, a lot of things, as you can imagine. But it did lead to tighter regulation and policy around environmental safety, but also set up a fund of money for people who lived in zip codes and areas around here. So we provide the health care for those folks as part of our patient base here. And it's money that comes in the form of a grant from the city now to fund that health care. Yeah. So I don't know lots of details or what you specifically were interested in, but it is an illustration I always use when I'm teaching public health students, nursing students in public health, about policy, the impact on policy, the importance of the environment in influencing our health on a daily basis, and the unknowns.
And the college does have a fairly strong faculty base and research base in the area of toxicology. I'm not an expert in that area, but they definitely are committed to it. One of another issue they've taken on is arsenic in the water supply, both in Mexico and Arizona. What's happening with the level of arsenic and how is that affecting health? So there is definitely a committed group of experts that, if you're interested, I can get you in touch with.
And, you know, we have two other projects going on here around that. One is an asthma project funded, where our promotores or community health advisors go out into the homes and they do assessments for people who think they have asthma or their children have asthma, looking at the environment, helping them clean up the environment. And then we also have another project around lead. And then, you know, I don't tend to think about that, but homes prior to 1978 in our community, there's still children exposed to lead. So once again, it's that community outreach promotora model that goes out and does that kind of assessment in the homes. Yeah, the sampling, yeah, so.
Rena?
The reason we moved to Tucson is because my husband wanted to specialize in preventive medicine, and that's how actually he ended up at Canyon Ranch, because back then, the residency medicine program had a collaboration with Canyon Ranch, where the residents will come in, and I'm wondering if that's still going on. I know it's called the Integrated Medicine Program now. If there's still, I know there was a gentleman from Minnesota or Massachusetts that came in and trained with Dr. Camona recently. But I'm wondering if locally, if we're doing that from the U of A or ASU, number one. And number two is, Enrich was one of the first graduating class for the Masters in Public Health. So he loves the program, he really, but I think one of the things that a lot of people don't have awareness of is how strong of a program it is. It's relatively new, but it's really graduated. A lot of people are very involved in, a lot of them stay in Tucson, and I think that's really great because you're taking that back and all these resources and collaborations. But I'm wondering if there's still linking that to the medical
So integrative medicine at the university is under the College of Medicine, and they have a fellowship training program still. A lot of it has gone to an online model system simply because providers don't have the time to leave their clinic for a year or two to come to Tucson and get the training. And so the model now is very much an online fellowship with very focused weeks where they come to the university campus and spend time in doing clinical rounds, learning different modalities for health promotion and integrative medicine. In terms of the preventive medicine at Canyon Ranch, I don't know.
Well, there are some positions on that team that are graduates of that program, that fellowship. We have one here that's a graduate of that fellowship, so they are, permeating our community. So that's huge for us to be able to keep those folks here in Tucson.
Well, my husband ended up working for Canyon Ranch for 12 years. He just recently left to go into private practice, but he loved it, and I just think it's such a great exposure. And I think he teaches preventive medicine at the U of A as his faculty, but I think a lot of doctors don't know what it means exactly. When you experience it, I think it's contagious. People really want to come in there and train. They just don't know enough about it.
I think it really lets them fill their toolkit of all kind of things. The medicine that we know they need to have, and additional things. All those other tools that they get through that fellowship makes them really powerful in influencing change in behavior, I think, too.
Yeah, for example, everywhere but here, when I go to new partners, the MDs especially if they're traditional
MDs.
I say to them, now, you're going to sit down with every person in this program for an hour. And the most common response, they look me right back in the eye and say, what the am I going to talk about with them for an hour?
And our physician was like, can I have more time?
Oh, she's a gem. She's a star.
She's a superstar.
Yeah, no doubt about it. But you have to get the whole healthcare system over that mindset that prevention is possible, and you can't take care of an entire person in 12 minutes.
And going forward, if you think about where we're hoping to go with healthcare discussions, we would be compensated on my ability or our team's ability to make you healthier. That part of our compensation, it wouldn't be based on how many people am I seeing every day. It would be based on how am I improving the health of this population or aggregate of people I'm caring for. And that's exciting. That's an exciting way to practice medicine or healthcare versus what we do now.
Now, is that based on what's going on with the new healthcare plan and such? I won't open the bag of worms because it's going to happen today.
Right.
But is that based on what people are labeling Obamacare or whatever? Is that the federal initiative coming into play, or what initiative is that?
Well, I think I see it coming on our side from the various insurance companies.
Okay.
We have projects going on where we have our normal payment methodology that the healthcare industry has always provided for providers. And then we have pieces that we're carving out of that amount of money that we can earn based on the improving health of the 73,000 patients. We're in a little bit at a time. In working on improving those patients' health, we would be compensated for that. So that data would be in the community. Look at this organization. Their folks have A1Cs, an indicator for diabetes. A1C are better overall. They're much lower. Or look, this population they take care of here, they tend to have a normal blood pressure or their weight or their BMI, whatever we're looking at. So that would be we'd want to be have that information out for you. Look, your doctor, here's how their practice does, here's how this health center does. You have that information. Because wouldn't you choose, boy, they must be good at it there, right? So I wanted to make my healthcare decisions based on data, rather than geography maybe.
I think it's being driven too by the fact that we're going broke. We don't have a choice. We're getting old, we're getting larger, we're having more health issues, and we just can't afford it. You're business owners, and you either have to decide not to provide care or provide very mediocre care because you just can't afford it. And so this is affordable. If we can keep people healthy, we can perhaps make it through this mess. And so I think a lot of it's just driven by the reality that we have to face the fact that we have a lot of health issues that we've kind of been blind to. And I would say the multidisciplinary, holistic, in my experience, and I have worked with integrated